Welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. I'd like to welcome Dr. Paul Buehrens and April German. Thanks for joining us today, Paul and April.
Good to be here.
For having us.
You're very welcome. By way of very brief introduction, because I like my guests to introduce themselves, Paul worked as a family physician for many years. It's up to you if you want to share how many. And he's the chief medical officer for, do you say VYRTY Corp, or do you just do VYRTY?
We just call it SYNCMD.
Oh, okay. And the developer of the mobile app, which is SYNCMD.
Yep.
And April is the chair of a medical clinical laboratory consulting firm. And we're all involved with the Healthcare Reinvention Collaborative. And I'm hoping I'll see you guys this afternoon again, 2 o'clock.
Yeah.
Okay. All right. Okay. So we're spending a lot of time together today. So today we'll be talking about, when we discuss current struggles in healthcare, most people do not think about how all of the issues in the lab it spills over into that and the serious implications for patients and staff. And through the Healthcare Reinvention Collaborative, I had a conversation with April, and she was the one that brought all these things to life for me. People don't think about the lab and its impact on the issues in healthcare. So I thought that would be a fascinating conversation to have today. And as we get started, I always ask our guests what you'd most like our audience to know about you. And Paul, would you like to go first?
Sure. Well, as you said, I'm a retired family practitioner. I just retired 4 years ago, and that's after a 4-decade career. So I joined a group in order to be just another cog in the wheels. And in short order, there was a leadership vacuum, and then I ended up in leadership with doctors in multiple different roles over years, trying to keep my company alive. And eventually we got consolidated into a hospital, had to change electronic medical records from good to worse again. And I realized in retirement that I couldn't give up my passion for improving healthcare, even though everything I tried had gotten worse over time instead of better. And I ran into Todd Otten on LinkedIn and joined Medicine Forward. The next thing I know, I'm being invited to Healthcare Reinvention Collaborative, and then I meet Primary Care for All Americans, trying to connect people, and have realized that everything I tried was failing because the forces of consolidation and transactions have been systematically destroying caregiving relationships for my entire career and after. And that's just not going to work. So I'm now pretty much committed to spend the rest of my time trying to improve healthcare by starting a movement, which should include, and this is really the message, all the caregivers and all the patients. And I'm sorry, if you're not a patient yet, you will be, which means that's everybody. That's enough.
Yeah, no.
How about April?
Good morning. Yeah. So I started my career as a medical laboratory scientist in my middle age. I was in my early 40s when I actually started this career, and I traveled around the country and worked for many labs, and then I ended up in leadership. And then I saw this degrade happen over time, where they're lowering standards, consolidating, condensing, and it's affecting patient care. So, there's been a mass retirement. We're on the backside of this pandemic. Things, our staffing shortages are greatly impacting us. And a lot of people think that we just push a button and watch a machine run, but there's so many things going on in the background to make sure that those, results are correct and accurate, and we're giving the providers the best answers we can give them so that they can, put together a plan of care and intervention to help their patients. So they rely greatly on us, but they don't really realize all the things that we have to do and the education we have to have and the understandings of statistics and quality assurance that we have to employ to make sure that those results are correct. And at the beginning of this year, I surveyed several laboratory leaders to figure out how I could best serve our community. And, you know, the voice was unanimous. And so I ended up joining our professional development group and coalition, ASCLS, and I've now been appointed to the Government Affairs Committee chair, and I will be doing a LabVocate Day in Washington at the end of September. So I really want to, you know, reach across the table. That's been part of my initiative, and I've been kind of pushing this and been cheered on by people in that community to reach across the board and get support from all care, like Paul said, healthcare givers. You know, we're in this together. We're in this for the patients. We're in this for ourselves as well, because we're patients too. And so it's important that we make sure people still get quality care. And together, Paul and I talked last Friday, and together we can be millions, and we can be a big voice, and we can stand up together and reach out across if we're all united versus being siloed in our own departments.
Yeah, absolutely. Thank you for sharing all of that. And if you would like to speak directly to the impact of consolidating labs, and then Paul can respond.
So one of the things that we have struggled with on our shortages is we've lost our leadership. You know, we've had, you know, mass retirement, just like everybody else. People have left for burnout, and we have a lot of young and new up and coming leaders, but because of the pandemic and the way everything happened, they didn't really get to experience that solid foundation growing into their leadership roles. Some are doing really well with it, and some are floundering. Our critical access hospitals are hurting a lot. But what the impact is I like to use a TSH, thyroid stimulating hormone, as an example, because I feel like everybody can kind of relate to that test and the importance of it. And so when you take somebody who has hyper or hypothyroidism, and the doctor orders, they're experiencing these symptoms, and the provider orders, you know, a TSH and some thyroid tests, and you want the right answer, because the right answer is really important to paint a picture to what's going on. Well, in order for us to make sure you have that right answer, we have to do a lot of quality control in the background to make sure that we are giving you guys that right answer. And what people don't understand is that, yes, the analyzer runs the test, but the collection, the storage, all of that stuff applies. And then also, we're putting on new reagents all the time. And so reagents can get damaged in shipment, temperature can affect things can happen internally in your system. So, you know, we're constantly running a quality control test to determine if you're getting that right answer. But what a lot of people don't understand is we design that. We put that together, and we provide the parameters for that. So if the parameters are set too wide, it compresses the data, and everybody thinks that they're putting out good results. They feel warm and fuzzy. They're putting out this really good results. Everything's clean. It looks good all the time. So they're going to miss if something's wrong. And with the testing system, sometimes in hospitals and labs, those parameters are set too narrow, or the mean is in the wrong place. And the parameters are standard deviations. I guess I should elaborate on that. And so when those parameters are set too narrow, it also disrupts care and causes delay, because people are needlessly retesting their quality control, troubleshooting, trying to figure out the problem. And so now we have a delay. And so when you have leaders that don't understand quality control design, you know, they don't have a strong foundation in that, they can impact the quality of care. Because let's take, for example, if it's too wide and you miss an error, you miss something going on in your system, and everything has shifted in the positive, and now you have a hypothyroid patient coming through, and they're getting their TSH tested, and now it's in the positive, and the provider sees that number, and they're like, oh, I need to make a medication adjustment because their thyroid stimulating hormone is going up. And then they make that adjustment, but the patient didn't really need it because the quality control was interpreted wrong that day. And so it's people don't think about how much all those numbers that we're doing and all those checks that we're doing impact that final result and that final treatment. So thank you, guys.
Yeah, no, absolutely. You explained that so well. Paul, what do you have to say?
Yeah, I think April brings up a big theme, and the big theme is about professional autonomy. My group started in 1946, and just a couple of docks right after World War II, when our town was only available by ferry ride from Seattle. Uh, it grew to a small group. I joined. I was the ninth man. Now more than half the medical school grads are women, right? But we had our own lab, and we had our own X-ray department, and I can tell you how profitable they were. Neither one of them made any money. We broke even on lab, we broke even on X-rays, but we weren't going to give them up. Twice in my career, my lab tech was able to tell me that my patient had leukemia while my patient was sitting in front of me. It took 5 minutes to do a CBC and look at the blood under a microscope and say, "Hey doc, your patient has leukemia." And when we consolidated, we were told you're just going to have a blood draw station from the consolidated lab, and you're going to have a phlebotomist who knows nothing else except how to draw blood. And all power to them, they're very good at doing that, but they can't do the lab, they can't interpret the lab, and I'm not going to get results timely. Similarly, if somebody comes in with a broken finger and I can't do an X-ray, I have to send them to the hospital to get an X-ray. That's just nuts. So when we consolidated, part of the deal was you can't take away our lab, you can't take away our X-ray. Yeah, we know they don't make any money. Too bad. So this is customer service, right? But what I'm talking about is we had a lab that had professional autonomy. They did their own quality testing, and they did it well, and we had highly paid lab techs doing highly good job. We had good X-ray techs. We had our own mammograms in our office for the longest time. And we could do really high quality care in one setting. And all the forces in America drive towards more profit, which means take out the professional autonomy, treat everybody like another button, make them work longer hours, burn them out so there are fewer employees, make them work longer hours, more time, document everything on top of it, which may have to occur after hours when you're not being paid. And it just very, very destructive. And that destruction looks on Wall Street like success because the companies doing it are making money. Meanwhile, the whole provider community is getting burned out and damaged. Here's a global solution. Put everybody on a freaking budget. Okay, that's the ACO concept. And actually, the guy who invented the concept is a college classmate. I ran into him at my reunion, and he said, "Well, if it's ever going to work, it's going to have to happen on a community level." Right. What if your community had the budget for your healthcare and everybody worked to the top of their professional license and had professional autonomy to do the best job they could with the license they have? I think we could provide far better care at far lower cost because half the doctors would be in primary care like they are in the other 36 advanced nations. We're the only ones in 37 advanced economic countries that don't have universal primary care and don't have universal insurance for everybody. And America seems to be stuck in its American exceptionalism and cannot understand that other countries are doing things better. But gee, number two spends half as much money as we do. And we spend a fortune on healthcare, but we don't get results. We have lousy statistics, lousy life expectancy compared to these other countries. And we're just organized wrong. And the reason we're organized wrong is that we're organized on a late stage capitalism model of manufacturing. And guess what? Healthcare is not making widgets or cars or raising crops. It's people to people. So we have to get back to where the caregiver, and that includes lab techs, excuse me, they're there to give care. That's why they're in it. They're not there because they like playing in the lab any more than I like the puzzles of diagnostics. It's about relationships. And everybody in healthcare is there for the relationships with the patients. And they're not being allowed to do what they can do. And that's just crazy. So yeah, we have a crazy system and it's got to change. Well, okay, how do you change capitalism from the top? Don't even try. It's not doable. You can change things from the bottom though. So if we can get everybody to understand what needs to happen, we can create a new paradigm. And it means all in free, everybody, not doctors running the show, not nurses running the show, not lab techs running the show, everybody in together.
Yes.
That's what'll make a difference.
Right.
Get 'em
Yeah,
moving.
no, absolutely. And I've just come to know about primary care for all Americans as well. So to give them a plug, I think that's such important work that they're doing. And April, I know that we were also going to speak to lowering of standards for medical laboratory professionals and how that can affect the results doctors receive from the lab, something else people might not be aware of.
Yes, that's something a lot of people don't realize is in most of our states, medical laboratory scientists are certified, but we are not licensed. So your hairstylist is licensed, your massage therapist is licensed, but we're not. But because we don't have licensing, some states do have licensing. I don't want to say it's every state, but the majority do not. And because of that, we don't have protections. We don't have the protections that the license provides. And so, that makes it, easier for hospitals to lower our standards and bring in lower care and bring in, they can do away with that because they are allowed to, because we don't have a license and we don't have that support. So we also, on our regulation side, we have very low standards for testing. So it could scare you to think that actually based on that, a TSH, go back to that, is a moderate complexity testing. So a person with just a high school level diploma can decide what your TSH result is. They're the one that can push the button. Is that where we're at this moment? No. But could we be there? Absolutely. If we don't start standing up and saying, we need to do something now, we need to have professional protections in place, that's where we're going to go. And we're already looking at other routes to try to fill these seats. I sat in on a CDC webinar about our staffing issues. And if we filled every seat in the medical laboratory sciences programs in the US right now, we would still be in a deficit. We cannot fill these seats. There's too many openings. There's an average of what they said was 3 empty positions per hospital lab and per lab. So that's huge when you think about those numbers. And because we're working harder and we're burning out. When I was a technical supervisor, I was burnt out. I was working on the bench. I was doing supervisor roles. I was on call. I was getting up in the middle of the night. I was dealing with, emergency things, having to go in and then go back to work and do my technical supervisor. And they burnt me to the ground because there was staffing issues. And my story is not a new one. And so we've got to figure out, and technology is one of the answers. It's multifaceted, and so I'll let Paul talk to that now.
I've started laughing listening because Medicare audits doctors for their coding, and they don't require a high school diploma for that job.
Oh, wow.
Think about that for a minute. Well, there are so many things we could talk about. The work that I'm now doing with Healthcare Reinvention Collaborative is brand new. The organization was started by 2 people last year. I listened to Primary Care for All Americans last week? I think it was. Jack Ricciuto from Cleveland was talking about how 2 people is what it takes to start just about everything.
Mm-hmm.
And we're also working on another 2. It's called the 2 loops model from the Berkana Institute, which is really about paradigm shifts and the kinds of roles that people have as paradigms grow and then die. And for all my career, the consolidation of medicine and healthcare in America has been occurring on a steady growth curve. And that consolidation looks like it can go on forever. And it's become very apparent to me, at least in the last few years, that it's already peaked and it's on the way down. And this paradigm of how to do things has reached its point of not functional. It's not going to work. There's a cliff ahead of it. And the cliff is when more burnt out clinicians decide to hang it up and quit, dumping all of their work on the remaining few, those remaining few won't be able to function either. So, if half your community primary care doctors were to go out into direct primary care, they'd go from seeing 1,500 patients to say 600, and that leaves 9 to be seen by the remaining few. And when enough of those folks leave, there's just an overwhelming volume for the remainers, and the remainders won't be able to function. So there's a cliff happening. There's also a baby boomer group of docs and group of other professionals, and they're all pushing retirement. And all it's going to take for them is for their 401k to do well in the stock market, and they'll be hanging it up early. Yeah. And when those folks go, who's left? And excuse me, I'm old enough now to become a patient, right? And I want it to work when I'm there. So there's not that much time left. Fortunately, we have tools now that can make things change really fast. And, throw some AI tools in front of docs, and they won't have to stare at the computer screen anymore. And ask yourself as a patient right now, why in the hell, in a world of AI, is my doctor staring at a computer screen instead of looking at me? Mm-hmm. And the answer is, Captain Kirk's computer is already here. You can have an AI tool autonomously listen to that conversation. The doc could talk into the computer and describe their physical exam. They can do their assessment verbally and do their plan verbally. And that computer can create an entire note right now. And there's no reason that it couldn't also do the coding and do the billing. Captain Kirk's computer on Star Trek can do all that. And we already have the tools, but they're not being implemented because technology in healthcare is 40 years behind.
Yes.
40 years. They're using stuff that was competing with MS-DOS in the 80s. This is nuts. So it's ripe for absolute revolution. It just needs to go away. And I don't know how that's going to happen in the current model. So the two loops model, I'm sorry, I'm going to go on a little bit. What happens when a paradigm is dying is that there are innovators popping up all over the place, and all of them start doing things differently because 1, they're burned out, 2, they can't stand it anymore, 3, necessity, the mother of invention, right? So innovators invent, and the mother of invention is what? So they're all isolated. They think they're the only ones. We can network these folks together now. We have the tools, including Zoom, podcasting, LinkedIn, Facebook, X, TikTok. There's ways to pull people together to see the same reality. And as innovators get pulled together, they find what's common among our innovations and what's not, what could work for everybody overall and what won't. And guess what that's called? The next paradigm. So I'm pretty much committed myself now to trying to pull innovators together to find a way to build the next paradigm so that when the other system collapses, there's something there to replace it. And there are going to be people who have to keep the old system going as long as possible because there's no alternative yet. There are lots of people who think they have the answer. I used to think that was the goal, was to figure out what the answer is. You know what? That's not how evolution works. Evolution doesn't direct itself towards an answer. It comes together and answers develop themselves. And if you don't believe in evolution, how come that COVID virus has mutated over and over and over and over and over until it's different than it used to be, and your old shots don't work anymore? That's called evolution. It's happening under our eyes. And evolution of the healthcare system can be directed by humans now. We know how. It's called networks. And networks first start by learning, then they become action, and then they become impact. And impact is, excuse me, dinosaurs know about impact. It's asteroid hitting the system, kaboom, and the next paradigm comes around. So, you know, the asteroid's already approaching.
It's it takes, sorry, I just wanted to kind of elaborate on that. I didn't mean to interrupt you real quick. But I started Lab Connections, and that's one of our things is we're working on innovation and trying to get rid of these menial tasks that are happening in labs so that we can get away from that and focus on the work we actually need to do, which is the patient work. And so I'm working with a software company right now to develop some AI technology, which is machine learning, so that we can, you know, kind of filling them with where we're at and where our problems are occurring in our field, where we can do away with all those menial, frustrating tasks that aren't necessary, that a computer can do. Like you said, staring at a computer. I don't want to be on the phone. I don't want to stare at a computer. I want to look at a microscope and get those answers to the providers and make sure my statistics are good. So I just wanted to elaborate on that. So I appreciate taking that direction.
Thank you very much for your work. You're both doing very important work in this space, and we need you. And April, one thing I wanted to ask you is how people in healthcare can impact legislative change and turn the tide when we unite across all areas of care. You were mentioning from doctors and nurses to radiology, laboratory, pharmacy, and all the other allied health services.
So if we go stand up towards in front of our legislators and we say we want this new initiative, or we want to push back an initiative that's been rolled out, or regulation that can harm us, if we go and stand before them and we say we're medical laboratory scientists, we only represent 10,000 people, and someone in big business or corporate world comes up and says, we don't want, it doesn't matter how much logic we present or how much rationale we present. If they step up and they say, we don't support this, and the government says, our representatives say, how many people do you represent? And they say, we represent 100,000. They're not going to listen to us because we aren't votes. But if you bring together all the providers and the pharmacists and the nurses and the lab and radiology and all the allied health, now we're millions, and then they have to listen to us. So that's where that's my biggest goal this year. That's my initiative, is to bring all of these areas of healthcare together. We work together for the health of the patients. We can work together to affect change and legislation.
Well, thank you so much. And that's what we're all trying to do, right? I think we're all united in that. And that's really awesome. As we start to wind down, Paul, I'm wondering if you have any top tips for your colleagues, from seasoned physicians to med students, or even those considering medical school.
You know, what's on my mind now is how social movements work. And two analogies. 6 women got together in Seneca Falls in 1840 and decided that women should have the right to vote in the United States. It took them 80 years, but by the time they got to the other end, there were millions of women marching in every city in the country. And they got the right to vote. It took 80 years. Now, Rosa Parks refused to sit in the colored section in the bus in Montgomery in 1956. And it only took until 1960, what was it, 5, when the Civil Rights Act was passed and the Voting Rights Act were passed. That was about 9 years. I don't think it's going to take that long for the next paradigm in healthcare, because we've got all the tools. And we need to understand that it's not doctors, it's not patients, it's not lab techs by themselves, it's everybody. And we need to be able to defend each other's professional autonomy and the right to prioritize caregiving and relationships over profits. And I don't know what the model is going to look like. I think it's going to have a lot more primary care and be local and community based, but I'm not committed to the solution. I'm committed to the movement. And unless we understand ourselves as doing a movement, we're not going to get anywhere. And that's where I've come to conclude. And it's after a long, long time trying to make the old system work and being shot down at every step. I mean, my company almost went bankrupt 3 times, and we found our way out 3 times. The 4th time, we got consolidated in. And now I can tell you, access is worse, patient satisfaction is worse, doctor satisfaction is worse, employee burnout is worse. And it's not all based on the pandemic. Part of it, a lot of it's based on hierarchical structures, loss of professional autonomy, and terrible electronic health record systems.
Mhm. Well, thank you. And so two of the things I just want to spotlight is I hope today, one, that we've raised awareness for people like people that work in the lab, pathologists, laboratory technicians, and even I would say, of course, there's many others, and I'd put radiologists in that, and it's like the healthcare professionals behind the scenes that patients, sometimes you'll thank your surgeon or maybe even your primary care doctor, but nobody thanks a pathologist, right, or a laboratory technician, or rarely a radiologist. And you guys are all working and you're expected to do more and more, faster and faster, and nobody thanks you when you get it right, but you darn well hear about it, right, if you get it, wrong. So just that, and even pharmacists, I thanked my pharmacist last week, and he just looked so taken aback. I said, I know how hard things are for pharmacists, because again, they have to fill more and more prescriptions in a shorter period of time, and nobody's saying, hey, thank you, you got that exactly right. But if something's wrong, they darn well hear, and that's what the person said, that they get yelled at all the time, and it's just not right. So just gratitude and appreciation and raising awareness for the healthcare professionals behind the scenes. And then the other thing I'd say is that, yes, what we're all saying is let's all be part of the change that we want to see, and we can all do something, right? And you can reach out to any of us, the organizations. So that is, I think, an important conversation that we've had. So Paul, how can our listeners reach out to you?
Go to Healthcare Reinvention Collaborative on LinkedIn, or try healthcarereinvention.com. Or I don't mind sharing my email address is buehrenspe@comcast.net, BUEHRENSPE. And, I'm happy to respond.
Okay.
And before we leave, let's not forget to thank the Kim Downey for being the ultimate connector. Who would have even thought to put a lab tech and a doctor on the same podcast, huh? Just Kim, because it's a bit out of the box. And yet April and I know each other a little, and there's mutual respect there. And that's how it ought to be. So thank you very much, Kim.
Yes,
You're welcome. Oh, go ahead, April.
No, thank you so much. I wanted to elaborate on that. I appreciate that. I appreciate that you're giving lab a voice and that you put us together. That's amazing.
Well, thank you so much. And it just seems like whatever two people I put together, sometimes again that you guys get ahead, you got to have a conversation ahead of time. You found some synergy, and just that we're raising, all of the voices, right? And then even I've had like a doctor and a patient on. So patients appreciate doctors, doctors appreciate patients, and just all the people that intersect with healthcare. And how fortunate am I to meet all of you wonderful, beautiful people right out there doing your very best, right? So thank you. I would have no podcast if people didn't come on it. So I'm just as grateful for you to be willing to come on and share your stories. So how can our listeners get in touch with you, April?
You can find me on LinkedIn under April German. You can find me at you can email me at april@labconnections.net. You can also get a hold of me on Facebook as well. So just under my name, April German, just look for me, request me, and reach out.
Okay. Well, thanks again for being my guest today, Paul and April. I loved having you. I think this is a important and different and interesting conversation to have. And, just gets people thinking out of the box and thinking a little differently. So
Absolutely.
I appreciate you both. So in closing, to move the needle in healthcare, we all need to raise our voices, and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.
Thank you.
Thanks, Kim.
You're welcome.